In this segment, I'm going to demonstrate a technique for an Atlantoaxial or C1 on C2 articular dysfunction in which we have as the main dysfunctional component rotation left. Because it's rotation left free, we have a right rotation barrier. This is a fairly simple muscle energy technique to do in terms of post-isometric relaxation, and then we'll also give you an example of a reciprocal inhibition with it. But with AA problems, our major diagnostic component tends to be a pure rotation without any side bending. If we can keep the side bending out of the technique, we will segmentalize the cervical spine, which has to side bend and rotate in its normal coupling manner at both occipital, atlantal, and C2 to 7. So without that side bending and without any flexion extension added to it, we can pretty much guarantee that the motion's occurring at that C1 on C2 level. So for rotation left, he's free left, so we're going to take him to the right. We take him to his rotation right barrier, add no side bending, and then just ask the patient to just gently rotate to the left. 1001, 1002, 1003, and relax. He relaxes. We pick up the distance just at that segment. Rotation left again, which is his freedom, and I'm pushing towards his right barrier. And relax as his position into the restriction, so it's a PIR, post-isometric relaxation technique. And one more time into that. And relax. And just keep taking him to his barrier. Some people prefer a patient positioning with this technique where the patient is elevated off the table. We're going to show you that from another position, from a side view in a second, where you might be able to see that positioning better. Now again, working with this atlantoaxial or C1C dysfunction, looking at it now from a side view, the patient has this rotation left dysfunction free. So his barrier and his true dysfunctional movement parameter is to the right. So I tend to hold the head, temporal parietal area, and then find the transverse process of the atlas, and with my third fingers monitor the posterior ring of the or articular process of C2, and that way I can see how far I need to go for that motion. So in that first positioning from directly above, we gave you this rotation left in this position, and now what we're going to do is show you how some people like to do it, where they lift the head off the table, find a flexion barrier to the entire cervical mechanism, and in this, we're also segmentalizing the cervical spine, and then we turn the patient to the rotational right barrier with the head in flexion, which anchors the rest of the cervical spine under C2 taut, and then have the patient turn back to the left, and the patient turns back to the left. Physician is pushing towards the right into the restriction, PIR, and relax. And then we pick up the new barrier to the right that way, and so on, holding 3 to 5 seconds, repeating 3 to 5 times. This tended to be a fairly commonly taught technique with the head off the table, especially for motion testing as well. In clinical experience with a lot of acute cervical injuries, with range of motion restrictions in multiple planes, I find this to be not as useful for those acute cervical traumatic patients who can't lift their heads up and in whom you have to keep the motion more neutral in the flexion extension. So I tend to just prefer the horizontal technique.